I'd like to welcome everybody, and for those Arabic-speaking doctors, Mbarak alaykum bagi shahr. My name is Dr. Lulu Al-Kaoud. I'm a R2 resident in the Kuwaiti Board of Surgery, and today I'm part of the members of Surge Kuwait. Today we have a lecture about inguinal hernia. It will be presented by Dr. Ahmed Al-Mulla. He is a senior specialist at Farwania Hospital in General Surgery. He graduated from the Kuwaiti Board of General Surgery and has a fellowship in minimal invasive bariatric surgery and endoscopy. We would like to welcome you, Dr. Ahmed.
Thank you very much. It's absolutely a pleasure and a privilege to be part of this family and this team. You guys are doing a tremendous job organizing such lectures. I think it will be beneficial for all level students, residents, and even consultants. So thank you very much to organize this lecture.
For joining us. It's a pleasure.
Thank you. So we'll start. Okay, so we'll start today. Our lecture will be a kind of casual lecture. It has all kind of levels from medical students to residents and even senior level. It's about a hot topic, a topic that everybody will be asked in the exam, and everybody has to know. It's like the bread and butter of surgery. We have to know absolutely everything about inguinal hernia. And it sounds easy, but sometimes it can be a little bit confusing. So without further ado, I would like to start my presentation with a quote. This is a quote from Sir Alston Baston. It's no disease in human body belonging to the province of the surgeons requires in its treatment a better combination of accurate anatomical knowledge with surgical skills than hernia and its varieties. So inguinal hernia is kind of tricky. You have to know your anatomy as well. You have to have a good round of knowledge about the pathology of the hernia itself, and you have to know. You have to have a good set of surgical skills in order to treat this defect or disease. So, introduction. We'll start everything with introduction. Definition of inguinal hernia. The inguinal hernia will be it's a protrusion of the abdominal pelvic content through a dilated internal inguinal ring or a weakened inguinal floor into the inguinal canal and out to the external inguinal ring, leading to a visible, easily palpable bulge. So this is the basic definition of inguinal hernia. There is a defect in the internal ring, which allows the pelvic content to go outside the abdominal wall into the scrotum or into the external ring. So the true incidence of inguinal hernia is unknown. However, it's more common in males than females, about 10 to 1. Lifetime prevalence in males about 25%, whereas in females about 2%. It's one of the most performed elective surgeries worldwide. Over 20 million of surgeries are done per year. This is worldwide. So we'll talk a little bit about anatomy. It's a surgical anatomy. So it is a passage in the anterior abdominal wall from the internal ring to the external ring. The internal rings is about, it's the opening of the fascia transversalis. It's just above the midpoint of the inguinal ligament, and it's lateral to the inferior epigastric and open, and the other end will be the external ring, which is the opening of the external oblique aponeurosis, which has two pillars or supports, which are each attached to the pubic tubercle or the other, which is the symphysis pubis. It's about 4 centimeters in the adults, and the direction of the canal it's downwards and medially. The content of the inguinal canal in males is spermatic cord and the inguinal nerve. In the female is the round ligament and the ilioinguinal nerve. Here, as in the picture, you can see the midpoint of the inguinal ligament. It's very crucial to know this anatomy, because the midpoint is different from the mid-inguinal point. The midpoint is the distance between the anterior superior iliac spine and the pubic tubercle. On the other hand, the mid-inguinal point, it has a different landmark. It's the landmark of the femoral artery. So this is one the landmark of the internal ring, and the other one is the landmark of the femoral artery. So the mid-inguinal point is the distance from the anterior superior iliac spine and the pubic symphysis. So that's what we have to know about the anatomy and the terminology of the inguinal canal. The layers. So as you go on and open the skin and to enter the inguinal canal, it's if you want to look at it, it's not a 2D kind of structure. It's a 3-dimensional structure. So once you open the skin and you go through the subcutaneous tissue from fatus and membranous, which is the campers and scapus fascia, you will go into the canal itself and how it is formed regarding the muscles surrounding it. So you get the anterior wall of the thing is covering above is the external oblique fibers and the internal oblique and the transversalis abdominis. The posterior wall will be the fascia transversalis and the conjoint tendon as well. The roof will be arching of the fibers, like you can see from the images of the internal oblique and the transverse abdominis muscle, and the floor will be formed from the inguinal ligament. So it's kind of a 3-dimensional if you look at it from the perspective of surgical anatomy. So what's exactly inside the anatomy of the inside the inguinal canal? The inguinal canal contains the spermatic cord. The spermatic cord, if you just remember from medical school or anatomy, it contains 3 arteries, it contains 3 veins, 3 nerves, and it's covered by 3 layers. So external spermatic fascia, the cremasteric muscle, the oblique and the internal spermatic fascia. And each layer, it has the specific content in it. Okay, so the arteries will be the testicular artery, the cremasteric, and the vas deferens. The veins, the pampiniform, and the vas deferens, and the obliterated process vaginalis. For the nerves, we know the genital branch of the genitofemoral, which supplies the anterior aspect of the scrotum, the sensation. And the sympathetic nerve around the testicular artery and the sympathetic nerve around the vas deferens artery as well. So what is the pathophysiology of the inguinal hernia? So it is in indirect inguinal hernia, it has the same, the indirect hernia pathway it has the same pathway of the descending of the testis from the abdomen into the scrotum in a fetal development. So in some patient, in some population, this pathway or the process vaginalis becomes patent. It doesn't close within late development of life in some children. So this patency allows the herniation of the abdominal content from the abdomen into the scrotum. Also, because the males have a larger inguinal canal with the spermatic cord content, it raises the incidence of inguinal hernia as well. The indirect or the direct hernia, it is a weakness of the muscle itself or transverse fascia, which leads to the herniation of content into the external ring. So types of inguinal hernia. We have anatomical types, which is according to the extent of the hernia itself. We have the pupinocele, we have incomplete, and we have a complete, which herniate into the scrotum. And we have, according to the site of exits, we have indirect inguinal hernia, which is the most common, about 80%. We have the direct inguinal hernia, and we have the combination, which is direct and indirect inguinal hernia, which is called bantalone hernia. We have, according to the content, we have enterocele, we have epiglotocele or omentocele, and we have cytocele as well. Other one, like a clinical types, we have a reducible, irreducible, we have incarcerated, strangulated, and we have as well the inflamed ones. So the special types of inguinal hernia, we have the sliding hernia. Sliding hernia is usually it's an indirect inguinal hernia, which part of the hernia wall is internal abdominal viscera. It's either colon or the bladder. We have rectal hernia, which contains part of the bowel wall as well. We have Litter's hernia, which contains Michel's diverticulum. ammonade hernia, which contains the appendix, and we have the mildus hernia, which is called the W hernia. It's very rare, but it's very dangerous because part of the bowel is inside the sac and the other part is inside the abdomen. So sometimes it will be a type of strangulation you cannot see because if it's inside the abdomen. And this is a picture of what I'm talking about. So this is the Mickels in the middle here, and we have the Richter hernia here, and the last one, which I was talking about, the W hernia, which part of the abdomen, part of the bowel in the sac, but there is a hidden part inside here. So as you can see, this side might be compromised or strangulated, and you cannot see it. And this is being misdiagnosed, and this leads to perforation and maybe complication for the patient. So other classification, this classification or NIHAS classification, it depends on the anterior approach. So when you open the hernia, you will see this will give you another classification of the hernia. So you will be looking at different aspects of the hernia itself. You will be looking at the posterior wall. You will be looking at the defect of the internal ring, and you will be looking at the type of the hernia as well. So type 1 will be indirect inguinal hernia with normal ring sac in the canal. Type 2 will be indirect hernia with an enlarged internal ring and posterior wall intact, inferior deep epigastric vessel not displayed, so the sac is not in the scrotum. And type 3A will be direct hernia with a posterior floor defect only. Type 3B will be indirect hernia with enlarged internal ring and posterior floor defect. Type 3C will be femoral hernia. And type 4 will be recurrent hernia. Type A is a direct hernia, B indirect, and C is femoral, and D is combination of A, B, and C. Another classification as well also comments on the sac, the size of the sac, the integrity of the posterior wall, as well as if there is any defect in the internal ring. This is one called the Gilbert classification. So all of this will give us an idea of what type of inguinal hernia we are dealing with. Is it an direct inguinal hernia, or it is an indirect inguinal hernia, or it's a combination of it's a femoral hernia, or even a recurrence. So it will give us a good idea of how do we deal with the disease itself. We as surgeons, we like to classify things. I think it makes things for us more easier and more organized. So what are the risk factors which predisposes this inguinal hernia or this herniation from the abdominal cavity into the to the outside of the abdomen? We have a long list of things. So it can be a chronic cough, it can be things which predisposes to increasing the internal the pressure inside the abdomen, which is chronic obstructive pulmonary disease. We have people who are operating on heavy machinery, people who are straining in like they are lifting heavy objects. We have people with chronic constipation, bladder obstructed disorders such as prostatism, or they have kind of enlarged prostate, leading to the inguinal hernia as well. Chronic smokers, ascites, obese patient, pregnant patient, previously open appendectomy. When we do an open appendectomy, sometimes you compromise the innervation toward the inguinal canal and causes weakness of the muscle, such as the iliohypogastric. When you cut it during the opening of the performing appendectomy, some people, they will come back with the inguinal hernia. Peritoneal dialysis, family history of inguinal hernia, congenital muscle diseases, and low birth weight. Low birth weight maybe will lead to a congenital abnormality leading to inguinal hernia. So when the patient will come to you to the clinic, they will present with sometimes an intermittent bulge. So it appears in the groin, upon standing or straining, but they are often asymptomatic or reducible. The patient, he knows how to reduce. Sometimes it can be unilateral, sometimes it can be bilateral, so it can be on both. But bilateral, they tend to be mostly, from my experience, it will be mostly in older people, in older population, and they are mostly direct because of the weakness of the posterior wall. But sometimes they can, so they can with, they can present as a symptomatic kind of presentation, which is most often. But sometimes they can present with a kind of an adverse event with a nausea and vomiting and signs of bowel obstruction. If of course, if it's delayed and the bowel or part of the bowel is inside the sac and the sac is compromised with blood supply, it can lead to ischemia and then subsequent perforation and then peritonitis, and the patient will be more septic. Examination, best examined when standing. The patient asks him to stand and cough, and will appear a bulging in the groin region. It's palpable smooth surface swelling or a defect will appear in the groin region. Indirect hernia, usually a bulge at the internal ring. Okay, the direct hernia, usually a bulge at the external ring. And then don't forget to examine the scrotum. Sometimes this presentation will be a undescended testicle, and this patient actually doesn't have a hernia, he has a scrotum inside the inguinal or the groin region. So how to examine him? Of course, we all learn from medical school. We obturate we block the external ring, the internal ring, and they ask the patient to cough. If we stopped it and the hernia is reduced, then it is an indirect inguinal hernia. If we have our fingers at the internal ring and ask the patient to cough, and it bulges out, that means it's most likely an direct inguinal hernia. Sometimes you cannot. You cannot differentiate even in the examination at the setting of the clinical. Sometimes you go and you think it's a direct inguinal hernia, and then when you go to operate in open or in a laparoscopic, you will see you're totally wrong. It's a direct or it's an indirect, or it's even a pantaloon hernia, which has a direct and indirect one. So it gives you a fairly good idea, but not for sure. It's a direct or indirect inguinal hernia. So other differential diagnosis. So even if we say it is a hernia, we have to think of other things. Okay, so it might be a lipoma. It can be undescended testes, as I mentioned earlier, a lymph node. Actually, I saw one patient who was 16 years old. He came to my clinic. He had a huge swelling in the groin region, and I was convinced at the examination that this might be a irreducible inguinal hernia. But this patient, unfortunately, when he did an ultrasound, it came to be a huge lymph node. And then when they took a biopsy, this patient was unfortunate to be diagnosed with lymphoma. So, and then he was perfectly healthy. He was 16 years old. Retroperitoneal sarcoma, it can be varicocele, hydrocele, testicular torsion. It can be an abscess or a sebaceous cyst collection. It can be a hematoma due to a trauma happened at that region. It can be a femoral artery aneurysm or a pseudo aneurysm. So all these things, if we are not sure this is an inguinal hernia, we have to investigate further so we not get surprised during the surgery. Now, when the patient comes to you at the clinic, at the setting of the clinic, you have to take a thorough history of what he has, okay, and then you do a proper examination of the inguinal region. So most inguinal hernias are asymptomatic. So most of the patient, they come to you, they might complain of like little bit soreness or pain or dull pain at the groin region, but some of them, they just discover them accidentally. They woke up in the morning and they see there is a bulge, and they didn't know about it for months, and it just happened. We have also to evaluate the patient if they have any chronic conditions such as chronic cough, constipation, or bladder outlet obstruction. If the patient has these kind of things, you have to be dealt with before the surgery, because it will be compromising the surgery itself. So you will take the patient, do for him surgery, put the mesh, whatever, or what type of surgery you want to do, and then the patient will have a continuous cough due to whatever disease he has. It will compromise the surgery itself and weaken the muscle further. So incarcerated or strangulated inguinal hernia, we have to deal with them as an emergency or prompt procedure we have to do for them. Laboratory test will be the same laboratory test that we do for any elective surgery or emergency surgery. Imaging, X-ray abdomen, not too much, unless the patient, I'm going from less expensive to most expensive. So X-ray abdomen is quite is free. Ultrasound and CT scan, they have to pay for them. So the X-ray abdomen will be the most easy, accessible one. It's not kind of helpful if it's asymptomatic, but if the patient is having some sort of obstructed symptoms, you might show some dilated bowel loops and collapsed bowel loops. So it will give us a fair, good idea about what kind of scenarios happening to the patient. Ultrasound, abdomen and pelvis, it's very good to identify the content and what kind of inguinal hernia he has. CT abdomen, it's a very sensitive imaging. It will show you exactly where is the hernia and exactly what content inside the hernia. So after you do all of this, you have to discuss the treating option with the patient. So if the patient is has risk factors, so large hernia, very painful, and he cannot stand it, well, you can go ahead and schedule him for surgery. Or you have any symptoms of strangulation or incarceration, you have to go and do surgery for him. If the patient has a small one and multiple risk factor, old age, he's in late 70s, ischemic heart disease, and it's only small hernia, and he's not symptomatic, I think he can wait for it. Maybe it doesn't need a required surgery after all. And the option of surgery, as we will mention later on, will be either an open approach or a laparoscopic approach, and this will be discussed further in the slides. So surgical options in inguinal hernia. So inguinal hernia surgery have been revolutionized throughout the decades. Open anatomical repair was actually introduced in the 1980s. And the concept of tension-free repair was introduced in the 1980s, and laparoscopic approach was described in the 90s in France. And now we are thinking about the future, and maybe robotic will be the future of everything. It's not only the hernia; it will be the future of like cholecystectomy, maybe the future of even obesity surgery. Nowadays, it's been used for every kind of surgery. So surgical techniques will be herniorrhaphy, which is tissue repair, tension-free, which is hernioplasty, or Liechtenstein mesh repair, which is the most common kind of repair nowadays. Nobody does the tissue repair. Laparoscopic, which is now rising, and it's very competitive, and people are very excited to perform this kind of surgery for patients due to its high results and good outcome, and the patient can go home earlier. And as I mentioned, it's robotic, but we'll discuss later what is the robotic and the surgery, the laparoscope, what's the difference, and is it worth it or not. So we'll start with the open primary tissue repair, which is herniorrhaphy. This was done late, like long time ago. I personally, I rarely saw any surgeon that does it nowadays. But there are some centers which are really specialized in kind of these surgeries, and they have good numbers of success. But nowadays, I think we are going towards the tension-free more often. So but however, it's been the mainstay of hernia repair in decades. So it's a simple repair with no foreign body in the groin. But disadvantage, if you are not doing this kind of surgery and you're not well trained on it, and the center is not very highly practicing this kind of surgery, will be having a high recurrence rate, such as from 5 to 20% in the primary and 15 to 30% in case of secondary surgery. And returning to the normal activity is kind of slower because of the repair and the nature of the healing process, and you are putting tension on the tissue in order to close down the defects. Now, the tension-free or the Langenstein mesh repair, it has been the open mesh repair has been the mainstay or gold standard from the 90s, from the 80s, and going to the 90s, and even in the early 2000s. I personally, we didn't start even doing lap hernia unless the late 2000s, I think in Kuwait. But we are well trained in open inguinal hernia. So Langenstein mesh repair is the most common performed, and actually I did a lot during my residency period. Other kind of mesh repair or tension-free are the mesh plug and patch, reed reverse, Kegel, Niehaus Kindle, and Wand's top and reverse as well. So it's basically we put a piece of polypropylene mesh, which is used to reconstruct the floor of the inguinal canal, and as well we have to support the inguinal ring as well. So basically, you are dissecting the sac. You cut part of the sac and then you reduce it inside the abdomen. After you dissect, you place your mesh, which has to act as a support for your surgery and your repair. And after a while, this kind of mesh will be as a concrete wall or a cement, preventing any content to migrate from inside the abdomen to the outside. So the advantage of it, it's very low and recurrent rate, about 1%. It's less painful. It is painful, but less painful from the previous one. And the mesh helps strengthening the weakening area. So it acts as a cement wall in that region. If you went back and saw any Langenstein or mesh repair, you open it again, you will find it's terrible and very hard to remove. It's kind of adherent to this area due to the inflammation that it does from the proline and reaction of the tissue, causing a kind of like a very, very strong net supplying or supporting this region. The disadvantage, of course, you're having a foreign body inside this region. So any kind of infection or any kind of complication habit, it's really, really a nightmare to go back and remove the mesh or to kind of deal with this this abscess formation or whatever. So it is a nightmare if you have to go in and remove the mesh again. So this is that. And then we are talking about laparoscopic. So laparoscopic, it's a new game. This is a new game that was introduced to us. It's kind of tough because we as surgeons, we are not very familiar to the pelvic region. This region is for us is kind of scary. Some surgeons are really, really scared of the pelvic region because it's high vascularity and it's narrow places. We as surgeons, we don't like narrow places. We like to operate in open space and we can see and dissect and be happy and re-anastomose and everything. But this kind of surgeries are, it's kind of tough. It's kind of a high learning curve for some of surgeons. So we have two types of surgery. We have the TEEP, which is the total extraperitoneal repair, and we have the TAP, which is total abdominal periperitoneal repair. The difference between them, actually, from the name, this one, the TAP, that we go totally inside the abdominal cavity. The other one, we go between the peritoneum and the posterior rectus sheath. So we go in between into the periperitoneal space. So laparoscopic anatomy, it's kind of different. It's different from the anatomy that we are mentioned earlier. It's more related to the myopectoneal orifice or of Fouchard, which is a different kind of structure if we think of it. The previous one, it can be three-dimensional. This one, we have to imagine it as well as a three-dimensional. So superiorly will be the arc of the internal oblique muscle and the transversus abdominis when you go inside the abdomen. Okay, lateral will be the psoas muscle, Medial will be the border of the rectus muscle and the anterior lamina, and the inferior will be the pubic pectine line. The retroperitoneal space inside it will be the space of Retius, which is a retropubic space, and the space of Borgos, which is a lateral extension of the Retius containing the inferior epigastric artery. So this is what we are talking about. So what you see here is kind of it's kind of like a cave inside. You have to know what is the layer by layer, and what structure surrounding it. So laparoscopic, this is a little bit about laparoscopic. According to the hernia surgeon 2018 and 2019 guidelines, laparoscopic inguinal hernia was promoted as a superior method of fixing the inguinal hernia rather than open repair. It has a good outcome. So when compared to the open mesh repair, it has less post-operative complication and pain, less hospital stay, and faster normal life resumption. Both recurrent rates are the same. Like there is no big difference between them when they did the comparison study between them. Nevertheless, only 10% of surgeons, they consider it as their primary. So still nowadays, some consultants, they are promoting to do an open surgery rather than laparoscopic surgery. Why? Maybe it is a harder anatomy. They cannot understand. They're not very well trained, and they don't want to do it. It has a longer time. This one, the open approach, you can do it within 40-30 minutes. This one maybe in an untrained hand will take like an hour and a half or 2 hours, maybe on one side only. It has a long curving learning curve. For TB, you have to do alone about 60 cases in order to master the anatomy and master the anatomy and master the strength of the inguinal canal. So, sorry. Just to get the charger.
No problem, دكتور.
بس الشارجر شوية راح عليه. ثواني بس. وش قصدك يا الشارجر؟
It's okay, Dictor. Take your time. In the meantime, I would like to remind everyone that if you have any questions, you can type it in the Q&A panel, not the chat box, and we will answer all the questions in the future.
Okay, sorry about that, guys, but this is the tax of technology. So as we said, it may require a longer learning curve. For the TEEP, you require about 60. This is the study was done, and you require about 60 cases to do alone in order to perfect or to know or recognize the anatomy of the retroperitoneal region. It has a difficult ergonomic. It's uncomfortable for the patient. For the surgeon, the patient is sleeping. So you have to stay in a kind of awkward position, and your hands will be, with time, will be kind of stiff. It's potentially dangerous complication because you're dealing actually with, you're dealing in the space which is highly vascularized. It's very small and confined place, and it has a very vital organs, structures inside, as well as organs. So the list of excuses is large. This has been some kind of intimidating for some surgeons. But I think we will discuss as we go on, and how can we overcome this kind of intimidation, and how can we overcome this kind of scariness, and how do we understand the laparoscopic approach. So just contraindication of laparoscopic hernia. So if you see this, don't try to attempt the laparoscopic hernia. Absolute contraindication would be inability to tolerate general anesthesia. You absolutely cannot do laparoscopic surgery with spinal coagulopathy because the pelvic region is highly vascularized. So if you get the patient which is on warfarin or on high doses of anticoagulant, I think you should be careful, and you do it an open approach much better. It can even control the bleeding. If there is an intra-abdominal infection, that is previously and a previous usage of prosthetic mesh. If there is anything, a mesh inside or infection inside causing an adhesion, I think it's unwise to do the surgery. Relative contraindication will be a previous pelvic surgery. The patient has any pelvic surgery before, a C-section in female. So when the patient has a femoral hernia, but she did a C-section, it's absolutely a nightmare to do TEEP or TAP. It will be a curtain of momentum, and you will see absolutely nothing at the top. If the patient had proctectomy or has any, sorry, it will be prostatectomy. Sorry, this one. So prostate surgery or prostatectomy. So I don't think it's wise to do to attempt the surgery for this patient. If the patient has a complicated appendectomy or even any bowel resection at that time, or diverticulitis, if there is too much adhesion and it's attached to the peritone, I think it's unwise to do it to begin for you. My advice, if you want to begin for a laparoscopic surgery for a patient in a TAP or a TEEP, try. If you are right-handed, try to start with the patient who's thin, slim, he has no previous history, a virgin abdomen, and try to do it a direct hernia first, and then you can, as you develop your skills, you can do indirect hernia, and then you can take much challenging kind of surgeries in the future. So this is how it will look like. So you will be, if it's for this drawing, if this actually the inguinal hernia will be on the left side of the patient. So your camera will be here, and the camera holder. I usually ask the anesthesia to put down the curtain, and the cameraman goes up to the head here, up to the head of the patient here. So he will be more relaxed, because if the camera holder and you're doing here hernia for 1 hour, his arm he will need the physiotherapy for the rest of his life. So the cameraman is nicer to be here around the anesthesia, or be just behind you here. So I don't recommend the camera holder man to be on this side. It's excoriating pain will be afterwards. And this is the ports. You can put a 10 millimeter, a 5 and a 5, and you can operate everything, put the mesh, everything from the umbilical port. But sometimes you can put a 10 here, and you can introduce, if you want to do a suturing for the peritone, and you can introduce the needle from here, or even a gauze. It's wiser to put a 10 millimeter. Even with the starting of your procedure, try to put a 10 here. It will help you to introduce the gauze much faster, and you put the mesh under vision, so it gives you help if you put a 10 in one of the sides. The trick is for this one, if the position of the port here, if they are at the same level of the umbilicus, it will be more for the bilateral inguinal hernia. So you can operate here, and you can operate here. But if you are operating on one side or unilateral, I think if it's a right side for the patient, you should have your left hand a little bit down here, so you can have some sort of triangle here approaching the hernia or tackling the peritoneum. So if it's a unilateral, I will recommend this one will go down like 2 fingers, 3 fingers down, and this one will be at the same level, so you can operate here, and vice versa. So once you open, you will see this, and this for some people will be absolutely, they would not understand what they are looking at. But there are some crucial areas you have to really, your eyes have to be very, 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 very used to in order to do a inguinal hernia. This is what you will see actually in TAP. So total abdominal periperitoneal repair. This is the abdominal cavity. So the first structure you will see here is the medial umbilical fold. The medial umbilical fold is obturated umbilical artery. So this will be your lateral, your medial point, or the medial edge, or the medial end, okay? And you will have here, as you see, the inferior epigastric. This is very crucial during your dissection, and this is a landmark to show you if it's this hernia is direct or indirect. So it will be part of the Hasselbalch triangle, if you remember it. The vas deferens always medial, going to the bladder here. The bladder will be in this region, okay? And then you have the gonadal vessels at this region, always lateral. And then you have the triangle of doom. These are the borders of the triangle of doom. And inside the triangle of doom is the iliac vessels. So iliac vein and iliac artery. The iliac vein will be lateral, little medial, sorry, and the iliac artery will be just in front of it. And here you have the triangle of pain, where all the innervation will be here. And if you injure it, the patient will have a chronic tingling sensation and even pain after the surgery. Here is the region of the direct inguinal hernia. And here is the region of the indirect inguinal hernia. So this is the triangle of Hasselbalch, the inferior epigastric and the inguinal ligament, and then the lateral board of the rectus muscle. So inside it will be a direct inguinal hernia, outside it will be indirect inguinal hernia. So this is that. This is the structure you're looking for, the structure you want to dissect from, and the structure you want to identify once you go inside the abdomen. So this is what you will see. So once you take the peritoneal fold down, you will see this kind of structure. So the hernia will, if the hernia directly will be here and reduced down here, you will see a defect here. If it's indirect, we'll see the defect here. And so this is the inferior epigastric. So this is the kind of border. If you cross it, you will be indirect. If you in that side, will be direct. So this is on the right side. So this is the gonadal. So it's more lateral. This is the vas deferens. Okay, so the triangle of doom is inside here. Okay, this is where the direct inguinal hernia will be. And this is the pubic bone. That's another structure you have to see once you dissecting the peritone. This is the psoas muscle, as you see it here, and you can see other structures here. And after you dissect everything, you can apply your mesh. So you have to be careful when you apply the mesh that it will cover everything, the defect, okay, and the sac is fully reduced, as well as the edge here is not folded and not touching, and making sure that the hernia will not escape from behind and go and causing a recurrence for the patient. So this is a TAP approach. So this is a TAP approach. So TAP is kind of it's a harder approach. It's nicer for the patient, but it's difficult to really grasp, because what you are working on a space which is between the muscle and the peritone. This space, it's totally you're dissecting inside blindly. So you have to know exactly where you're dissecting and your plane. Otherwise, you will be going into a false plane, causing more trouble for you, and you will be absolutely lost. And even if you go through the peritoneum, the air will escape inside, and you will lose the field completely. And you have to either you convert to open or you convert to TAP. So what do they use? When I was in Brazil and was in my fellowship, they used to use the camera itself for dissecting. But some people, they find it easier to do a balloon. So there's a balloon, they introduce it into the space, and they inflate it, and then they do the dissection of the cause the periperitoneal region, creating the peritoneal flap. So, and then they're allowing the ports to be introduced again so they can work out the hernia. So the advantage of the tip itself is the mesh itself, it doesn't require any fixation, because once you put it inside and you deflate the abdomen or deflate the region, the mesh will be just stuck in there, and the peritoneal actually will act as the fixing equipment for the mesh. You don't have to enter the abdominal cavity, so the abdomen will still be a virgin. Okay, and we'll show you later on. And less painful because you're not opening a muscle. So you're only working on the periperitoneal spine, and you're not actually piercing any muscle going inside the abdomen. Less post-operative pain, that's what I was mentioning earlier. Limitation of this one, it's kind of hard. It's a very confined, small place you're working in. So it's a small working place. It's and the anatomy in there is unfamiliar. It's kind of opposite of the tap. At the tap, you can see everything in front of you. Inside the abdomen, everything is there. You inflate the abdomen, and you can see the structures. You can see the vas deferens, and you can see the gonadals if it's a thin patient, and you can see the iliac vessels, and you can see the hernia as well, the defect where is. But in the tip, it's kind of tricky, and we can see it in the next slides. So, as I mentioned, it's hard and it's tough, and it's really kind of difficult to deal with. But nothing is difficult once you practice it, that you have a system in your hospital or your practice. If you have a system, then you will implement the system, and then it's very easy to teach your skill, you teach the skills that you learn to other people. If you go in and you just ask some colleagues or ask some resident or ask some trainees, you just dissect here, dissect there, and dissect everywhere here, he will not have an idea. Personally, when we started doing laparoscopic cholecystectomy, we made sure that we have the critical view, and we made sure that we get this critical view done and dissected well before we clip or before we cut the artery or we cut the cystic duct. So achieving a critical view or achieving a safety kind of environment inside the surgery, the teacher will be relaxed, the student will be relaxed, the resident will be relaxed, and all going to learn more about the procedure rather than going randomly, like you going from one surgeon to another who is just creating his own system or his own thing. So what I'm talking about is how can we make it easy? How can we improve? So when I read some studies, and I already wrote an article about this one, it's some surgeons they had to learn the pelvic anatomy by performing an open surgery. So they did around 61 patient stop procedure just to dissect to have a fairly good idea about the pelvic and the posterior rectus sheath and the periton, and how to dissect this region, and then they implement it on their practice. Another concept is standardization, which means that all if you have a system and that you really trust and you implement it to all of your residents and your colleagues, all of these students will implement or will practice the same thing, and then you will give it a standardized, so you know exactly when you go in what to do, what to see, and what to have, and if you have an injury here or injury that you can deal with it immediately, and also achieving a critical view. So you have to have a critical view that at the end of the surgery or when you want to apply the mesh, yes, this is what I need to see and this is what I need to find. No, I don't leave anything behind, and when I put the mesh, I will be very relaxed, and when I deflate the abdomen, I will be in my mind, this patient will be okay. So this systemization was introduced in 2019 There was described recently approach which is implemented in the concept of achieving the inverted Y and the 3 zones and the 5 triangle. So this is the study which is talk about standardization and the critical view. And this one was the study of systemization. Actually, one of the authors was my mentor in Brazil. So he really implemented, and he taught me how to implement this kind of systemization. And now I'm already teaching it in my institute, and how can this improve the surgical skills of the surgeons with me. So using a virtual simulator, yeah, it will help. Okay, they can different model, maybe starting with a small homemade and then animal laboratory and cadavers. So practice. Performing under experienced supervision, it's very helpful. So if you have some people which are very experienced in TAP or TEEP and they are always around you, it will boost your confidence. It will decrease the learning curve. You make learning very fast from maybe doing 60 cases or 50 cases alone or 100 cases alone. You will be doing maybe 10 with the superior or supervised supervision. It will give you a boost and it will give you a much confident, and you will pick up more faster than just doing it alone or just start to learn. So when talking about the zones, they have 3 zones. Okay, zone 1, zone 3, zone 2, and zone 3. This is in TAP. And even it can be applied in TEEP as well. But why do I have zones? Why do I think about zones? Okay, because when I start dissecting, when I create the inguinal flap, when I used to see before I went for a fellowship, I used to see my colleagues perform the surgery. They kind of go everywhere. So they can start in the middle, and then they can jump into the lateral, and then can jump to medial, and then in between, and then they apply a mesh. So they don't have a kind of system, and they don't really have a true system. So I really had a difficult time to understand what they are doing. So when this system was introduced to me, the zones, I kind of have like 1, 2, 3. This is what I have to do, even if it's a kind of robotic kind of thing, but at least I have some sort of understanding of what can I do. So when I usually start, I start with zone 1. Zone 1 is the safest zone. This is most lateral. So what I have there is the psoas muscle. So I know there is psoas muscle and the triangle of pain. So I really know that there is no major catastrophe will happen in that region. So once I dissect the peritoneum from the fat, I know exactly in my mind that what is my extent. My extent, it will be to the psoas muscle. So I can see the psoas muscle. I reached my zone, and then I will jump to zone 2. The zone 2 is, they call it the tunnel of light. So here, the most crucial thing, or most difficult thing, or most dangerous thing they can go across is the corona mortis, which is a abnormal vessel coming from the obturator artery. So injuring of this one, it can be kind of tough for the patient, and it's difficult to really control during the surgery. And then afterwards, you go to zone 3, which is the triangle of doom. So after you dissect these kind of zones, you can go back into the difficult, the most one you have to really dissect, and then slowly you can achieve your inverted Y. The inverted Y is, as you can see here, the gonadal and the vas deferens, and then here you can see the inferior epigastric. So some tips, if you go and dissect and you see the inferior epigastric down here, you are in the wrong plane. So you have to have only the peritoneum down here. You have to have nothing from the above downstairs. Okay, so this is the zones as we mentioned earlier. Okay. And then achieving the triangle. So these are the triangles that in our mind that we can see. If you can really concentrate, you can really relate to the triangle. Like if you go back to the picture I placed in the beginning of the laparoscopic approach, you can now relate what is the triangle, and you can know exactly when you go inside what can you expect. So this is the triangle of pain, which is the psoas muscle and the zone 1. Okay, this is here the triangle, the femoral triangle is down here, whereas the obturator as well. Here is the direct hernia above, and here is the indirect, which is just at the apical of the triangle of Doom. And this is the triangle of Doom surrounded by the spermatic vessel and the vas deferens. So once you go inside and you can imagine what you have in here, and you have a structure, and you really think of it, it becomes more clearer, it becomes more easier, it becomes more relaxed, and with time your eyes will be very useful to this kind of appearance. So I think it's very helpful to achieve or to recognize such zones and recognize such triangles in the repair of the inguinal hernia. So these are the triangle. Okay, so you have the triangle of doom of disaster, triangle of pain, triangle of Hasselbank, triangle of indirect hernia, and triangle of femoral hernia. Okay, so each has its own useful. So this is a video. It's a kind of long video, but I'll go through it. Okay, of TAP. So total abdominal. It was performed by my mentor, and it's really how I really approach the inguinal hernia repair. So going inside, here is, I think he used to repair it. So this is so if you see here now, if your eyes are very used to what I used to mention before, you can see this is the inferior epigastric will be here, okay, and this is an indirect inguinal hernia. This is the gonadal, okay, and this is the spermatic will be in here, okay, kind of here, and this is the triangle of doom. So this is how because see, if you can see here, the camera is just at the umbilicus, and then one hand, because it's on the right side of the patient, one hand will be kind of at the level of the umbilicus, the other hand will be slightly downwards to achieve the triangulation and to make it easier for you to dissect. Okay. Yeah, so he's starting here. So where the anterior superior iliac spine, and then he's making up like a dot. And I always do this. I do a dot, and then I just kind of connect the dot kind of thing I do. So I create this dot and then I follow it. It's more practical for me rather than just opening the peritoneum. Okay, so he said there is the inferior epigastric, we have to stay away from it. Okay, so see how he approaches it. He takes only the peritone. So once he opens it, he allows air to dissect the peritone. In this region, the fat should be away. So you shouldn't have any fat going with the peritoneal flap, because you want to protect the triangle of pain. So all the nerves will be behind the fat. So you have to have some sort of cushion to prevent any injury to the nerves and leading to pain postoperatively. So this is that he reaches to the medial fold. Okay, medial fold. So this will be his flap. See what I mean? Now he's just dissecting the fat, the peritoneum from the fat. So he's not allowing any fat to go with the peritoneal flap. So this is where he starts. He always starts with zone 1. Okay, so it's the most safe zones, and he can dissect easily, and he knows that this region he will not injure anything in the beginning of the procedure. Okay. So here, after he finished zone 1, he jumped into zone 2. So here is zone 3, but this is actually zone 2. He's going here. So if you see this kind of what do you call it, flimsy layer, you are in the right place. If you are struggling in this region, you are not in the right place, because this happens with just a simple dissection. You will reach this region. So he's going through the tunnel of light. Here, actually, when you go to zone 2, okay, the fat should go down. It's not wise to be up. So here, as he dissects, he will reach the pubic tubercle, or the bone itself, and this is the bone. You can see this is the bone. And down there will be the bladder. So he will dissect like 2 inches below the bladder. Now he's tackling the hernia, which is zone 3. Okay, and you can see now the hernia sac. Maybe the edge, this is the edge of the hernia sac. You can see it's here, the edge of the hernia sac. So you can do it with the diathermy if you're experienced. You can do it with Merlin if you are afraid in that region. You can do it with a scissor if you are experienced. So there is a fat inside, lipoma of the cord. Okay. So he's continuing to dissect. This is the hernia defect, as you can see. Okay, so he's continuing to dissect. This is the bone, okay, and here actually this is what appears here is the iliac vein, okay, and this is the inferior epigastric. See, this is the iliac vein. Okay, so he's continuing to dissect in zone 3, which is the dangerous zone. Okay. So he's dissecting the hernia here. Or the peritone, he's dissecting the peritone. He's pushing the peritone medially. He's pushing the peritoneal content, the cord content medially, and he's kind of pulling the sac downwards. So this is here. Here is the gonadal vessels. Okay. Here you can see this is the gonadal vessels. Okay, and this is I think is the spermatic, the vas deferens. See, this is the inverted Y. Okay, so he's pulling it down. As you go down, see? Okay. So he's dissecting more to allow to open all the orifices here, the femoral, the obturator. So he can make sure there is no hidden hernia there. Sometimes there will be hidden hernia here. So this is the vas here. You can see it. It's kind of touching on it. So he has to dissect around 2 centimeters below the pubic bone. Okay, this is the obturator nerve here, if you can see it, and maybe this is the corona mortis here. Okay, see, he achieved the inverted Y. Now he's completing dissection kind of laterally to allow to place the mesh, or to give a space for the mesh. Here it will be the psoas muscle. Okay, so here he achieved the inverted Y. So here the gonadal and the spermatic cord, and now he's trying to because the sac was too long, so he's closing it to decrease the seroma and to maybe there is no hydrocele afterwards. So just fast forwarding this one. So this one he's going to apply the mesh. So the mesh, this type of mesh is a pro grip, so he doesn't need to tuck it inside. Okay. And he just see how he achieved the inverted Y. And now he's just spreading it inside. It has a mark, that's the medial. He's making sure that there is no fold here, and all the fat is just behind the mesh, and he's covering the hernia. Okay. And now after covering the hernia, he's creating a space for himself because maybe he was short. And see how the end result, everything is covered and it's nice and there is no fold and it's very relaxed and tense. And then he will close the peritoneum by suturing, so it's less painful for the patient, or you can use the tucker if you want. Sorry. So just fast forwarding. So this will be the end point. Yeah, so this will be the end points. So everything is kind of tucked and nice. The tip is a different story. Now, how to enter inside it, it's kind of difficult as well, because you have to introduce a varus needle just before the pubic bone here, okay, or pubic symphysis here. You open a small opening and then you introduce the varus needle. The varus needle should not be inside the abdominal cavity. It just has to be in the periperitoneal region, and you can feel it. And then what he's doing, he's feeling the bone here. He's actually rubbing on the bone. So once he achieves the space, now he can inflate. It's kind of tough. You have to be very practiced on this region. So now the air will be in between the muscle and the peritoneal region. This one will allow creating this kind of space, and he can feel it by touching the rectus muscle will be rising, so you can feel it here. So then he can go from us. We can go with a VisiPort, but he has only the one without the vision. Okay. So he's going inside. This is what you see. Absolutely, you cannot see anything. He's going blindly, but his direction will be straight to the pelvis. So he's actually going inside and touching the bone. He's actually rubbing against the bone itself, and then he will go medially and laterally to allow to create a space. So this is what you see. Above here is the posterior rectus sheath, and down here will be the peritone. So the bowel content will be downstairs. Actually will not breach it. So he's creating now space for the other ports. He has to be very careful to dissect, because if you breach the peritone, it will be a nightmare for him and for the procedure. All the air will go inside and inside the cavity, and the peritone will rise, and the vision will be totally obliterated. Sorry. It's the same setting as the tap. Okay, so he's now dissecting. And here, actually, what he's dissecting this is the midline. And if you can concentrate more, you can see the needle here. Here, you can see the needle. This is what he's trying to achieve, to see the needle. And that means that he's in the right space. So what's down here is the bladder itself. Okay. So he's keeping the needle as a guide that shows him that he's in the right place. So this one is actually zone 2, where the bladder is. Okay, so this is the bone, and he's going lateral. This is maybe the corona mortis. Okay, so he's now dissecting. And this is maybe this is the hernia. So that's the hernia. Okay. It's kind of, if you are not used to it, it's kind of divide. I had a long time to really understand or grasp. This is the psoas muscle that he's pushing against, trying to achieve zone 1. So if you get the concept of the zones, you will not get lost. You know exactly what he's doing and where is he at the moment. So he's trying to dissect the hernia or reduce it. This is the, okay. So he's pushing all the cord content medially and he's trying to dissect it laterally. As you see, it's a very small place. If we cannot create for you a space, this surgery will be horrible. Okay, so he's dissecting it. This is the vas, and this is the gonadal. So this is the vas. It's kind of close to the vas. Now I know it looks like a nightmare, but he's very professional. See, as I told you here, this is like the vas. As he's pushing, so he's kind of creating the inverted Y again. So this is the vas. Behind it is the iliac. It's pulsating, and then he's trying to open all the spaces, even the obturator and the femoral. Okay, maybe he has some sort of femoral hernia here, but I'm not sure. See, and then that's the end point here, the inverted Y. Here is the gonadal, and here is the spermatic. So once he reduces it down, this is the psoas muscle. Okay, so once he reduces it down and create a space for himself, it's absolutely beautiful. See how it's dissected very neatly. Very neatly it's dissected. It's absolutely beautiful to dissect. If you know this procedure, it's absolutely beautiful procedure. But this is the inferior epigastric, and this is where the hernia is. So it's a direct inguinal hernia. And this is maybe the obturator artery and the corona mortis. So this is what he's wanting to achieve, the inverted, okay? So after he's fully dissected, after he fully dissected, and this is, okay. So it's only cleaning the region, okay? He will apply the same program mesh, which he can apply any sort of mesh in this region. It can be a Prolene mesh, it can be a 3D mesh. It doesn't really matter because you don't need fixation, okay? So he introduced it, and in this region, the program mesh is a nightmare because it will stick to everything. You don't really like it. So he's trying to spread it. Again, the green mark is the medial, okay? So once he spread it, it's nice. Very nice. Okay. So it's really spread, and see the edges it's not connected, it's not folded, so the hernia will not escape. And then he's allowing it. Now he will leave it there, and he will just hold and deflate. And then the peritoneum will do all the job, and the peritoneum will do all the job for fixing the mesh in place. So if you go inside the abdomen, you will see it is fixed and it's nice, and it's part of the peritoneum. So what about robotic surgery? So robotic surgery is an emerging technique. It's a very well, it's not really well established. We don't know really. It is really for now or for the near future. It's just coming up. So there is no enough studies to compare the robotic to the laparoscopic. It's really, there is no superiority over the other, but I think it will give us a better ergonomic because your hand will be 360, better visualization. It's a 3D. It's a high precision for stitching the peritoneum or dissecting small peritoneum. It's much easier for suturing maneuver and better to placement of the mesh as well. On the other hand, robotic requires learning curve. So you have to learn how to use the robotic first before doing the procedure. So you have to learn how to do the robotic, and then you know how to do the tap in robotic. So it will be very, very tough and time consuming. But I think the future will lead us towards this kind of procedure. It's very costly because the maintenance versus the laparoscopic, because you have to maintain the robotic and they have very part spares and things. It's laparoscopic, you need only the camera too, and some equipment. There is, as I mentioned, not enough data to support superiority over the laparoscopic. The same, both have the same. And I think robotic, when they don't have smaller ducts, you have to have bigger one. But in laparoscopic, in TEEP, laparoscopic, not TAP, TEEP, because TAP you have to really fix the mesh if you're not using the program. You can use the mini laparoscopic, which is a 3 millimeter, and it's very small, and even doesn't require any suturing afterwards. So tips to overcome laparoscopic hernia. So an extra torque is always helpful. If you are really struggling, you can put another 5. Don't worry about it. Right-sided direct inguinal hernia is always easy to begin with. So if you want to really start with something simple. Don't start with a complicated left-sided sigmoid inside, very indirect inguinal hernia, and then you will get struggled, and some senior will come and take the case, and you'll feel frustrated. Start with something simple and then progress. Intraoperative bleeding can be managed with direct pressure. If there is any small bleeding, really in the pelvic region, if you go in, you will find small vessels that really cannot stop. Just put the pressure on them or clip them, or maybe you can suture them if you are very skilled in suturing in confined places. If you are injured, a major vessel require conversion, just convert. Don't struggle. Open the patient if you injure the iliac or the vein or the artery or even the inferior epigastric and you cannot control it, just open the patient. If you injure the bladder, you can suture it. It's okay, or you can call the colleagues from urology and they can stand with you and help you or guide you. And put a Foley's. I think the bladder is very friendly with the surgeon. If you injure adjacent organs, you can suture it, small bowel, or if it's small opening, you can suture it, or even if a small burn you have, you can suture it. In case of TEEP, increase in intra-abdominal pressure. If you puncture the peritoneum and there is an increase in intra-abdominal pressure, you can put an intraperitoneal, intra-abdominal 5 millimeter trocar and act as a vent. So you put it inside the abdomen and you deflate it, and the air will escape through the trocar. So it will allow the peritoneal to go down and you can work in this space. ETEP and minimal laparoscopic kit are a good solution in small places like TEEP. So as you saw, in TEEP, it's very confined place. If you use a minimal mini laparoscopic kit, you can maneuver in this place very quite easier than the normal 5 millimeter. And ETEP can give you a broader kind of field. You can go, and even you can go and as far as doing a posterior compartment separation with the ETEP as well. So complications in hernia, open or laparoscopic, it's kind of similar complication. You can have recurrence, you can have seroma, you can have hematoma, you can have a chronic groin pain, you can have ischemic orchitis, testicular atrophy if you injure the testicular vessels, injury to the vas deferens, bowel, bladder injury, hydrocele, rejection of the mesh itself, erosion, prostatitis of the pubis if you suture the osteum, wound infection, and prosthetic complication as well. In some complication, it can be kind of severe. In some, you can really deal with it at the spot. So in case of hematoma, I came across some patient with post hernia repair, laparoscopic with a hematoma. It's quite okay. You just reassure the patient and ask them to put a hot compression on that region and then take some NSAIDs, anti-inflammatory, and wait for 2-3 weeks, and then it will go away by itself. Don't attempt to go inside and evacuate the hematoma, and don't put a needle inside and aspirate. It's just a disaster, and you will reduce infection. This will go as well with the seroma itself. Chronic pain in that region, if there is an interruption of the nerve itself, the inguinal nerve, you can apply a local anesthesia at that region, or you can block the nerve itself, or do a nerve ablation as well. So the pain gradually will go away by time. If there is a rejection or an erosion, or maybe a wound infection, you have to deal with it at the spot. So if there is abscess, you have to open it, and sometimes you might need to remove the mesh itself to save the patient's life. So things to remember: knowledge of inguinal hernia anatomy is the essence of successful surgery. Laparoscopic inguinal hernia is getting a lot of attention nowadays, so due to the success result and post-operative outcomes. Robotic surgery is an option, however, still lacking data to prove superiority. Implementing systemization and encouraging standardization is the key to produce a safe surgeon. Learning multiple hernia procedures is a good arsenal for you. Like, if you know how to do a tip and tap and then open, it's a good option in your arsenal. Don't be afraid to improvise when you're stuck. Maybe when you go into tip and you get stuck, convert to tap. If you're stuck in tap, you can convert to open. Converting to open is not always a failure, and it's not even a failure. It's just saving a patient's life or completing the procedure itself. Okay, so this is my reference. Thank you guys very much for listening. I know I took a long time speaking, kind of awkward when you speak and nobody's interacting. So
thank you very much, Dr. Just there's a few questions in the Q&A panel before we go to our MCQs.
Yeah. Okay, we'll go to the questions and see how it goes. Okay, so Tariq, which is the better approach in laparoscopic hernia, tip or tap? According to the hernia surgeon 2018-2019, tip was superior than tap, to be honest here. But tip is very hard to learn. And for my opinion, this is my opinion. It's nothing to do with the study. If you know one procedure, stick with it. Like if you know tap and you like doing tap in laparoscopy, just stick with tap. Okay, so that's that. Anonymous attendant, management, surgery, tech. As I mentioned before, you can do a local anesthesia, or can give the patient initially local anesthesia, pain relief. And then if he's still having the pain, you can do a local anesthesia or regional blocking of the nerve, and this usually works for the patient. That's it, I think. Epidural will work, right? Mary, epidural will work, right? I'm not sure about epidural really, but maybe I will go and search it if it's epidural will be the answer for you. So should we check? Any other questions, or I'm okay?
These are the only questions so far.
Okay. So shall we go to the MCQs or wait for more questions?
We shall go to the MCQs.
Okay, so question number 1. We'll allow them to read it and then we'll answer it. But just tell me if the answer will appear.
Okay, we'll put the poll right now.
Okay.
Okay. We'll give them now 1 minute to answer.
Okay.
Okay, teacher, so most of them answered A.
They are good in anatomy.
60% of the audience.
The English doesn't go. Oh, مشكلة. Okay, so can I go to the next slide? How can I go to the next slide? Okay. Okay. Okay, so next question.
We'll put the poll now.
Now, the previous question, 50%, they answered it? Oh.
60% answered A.
Yeah, so yeah, they're good in anatomy.
Then this question, the 1 minute is running. What ischemic orchitis after inguinal hernia repairs more often do?
Mm-hmm.
So we have a few seconds left
Mm-hmm.
for the final votes.
Mm-hmm.
Okay, so most of them answered C, an adherent ligation of the testicular artery, 42%.
Okay, let me close this one. I don't know why it's stuck.
I think it needs a while.
Maybe.
Try clicking on your PowerPoint and then click the arrow next.
Okay, so it's C.
D?
Yeah, it's completely excising, so not of somebody. Okay. Oh, sorry. Maybe didn't see.
Okay, so a 50-year-old man presents with a small asymptomatic reducible right inguinal hernia. Which of the following is true about the condition?
And contain.
So around 30 seconds left. So
So وين راحت أنا؟ Actually it's C. So I was waiting until some شباب كلهم all the oral surgeons they want to operate laparoscopically.
Prepare the best option.
Actually, it's أنا حاطها على the wrong one, but it's actually waiting symptoms there. So all the surgeons there, they want to do a laparoscopically. Actually, it's a wise idea to do laparoscopically in elder men, because operating on, there is a small point, is operating on a patient who's young in a laparoscopic approach. Maybe in the near future, in the far future, this patient has some sort of prostatic disease. It will be really horrible for the urology people to dissect in that region, especially if there is a mesh. So it's right there. It's wise to do laparoscopic repair for a kind of older, if he doesn't have any prostate symptoms. Anyway, so next one. While performing a laparoscopic surgeon identify a medial umbilical fold on the deep surface of the anterior abdomen wall. The medial umbilical fold are caused by, it's there on?
Yes, the 1 minute is starting now. I think this is a different question, Doctor.
Yeah, it's a different question. No problem.
Dr. Ali, try to change it first.
Let them finish answering this one and we'll put
They can do it. You know, they answer it well.
So 43% answered A. Most of them answered A, and 32% answered B.
Okay. The superficial, it's the only one wine. So I think B is the answer.
The correct answer.
I'll share the current question on the screen now.
Yeah, and the current question is, yeah, this is my question.
Yeah. So while performing laparoscopy, the surgeon identified the umbilical fold.
Medial umbilical fold, which is deep surface of the anterior abdominal wall. The medial umbilical fold are caused by
Most of them answered D, obliterated umbilical artery, 37% of them.
Yeah.
Okay.
This is the previous one.
Yeah.
Yeah, so it's the Inguinal one. Okay, so that's it, I think. The end of the
question number 2. A lot of them answered this wrong. Do you mind discussing it with them?
Which one?
Question number 2.
Which one is it?
If you go back, It's this one.
Yeah, ischemic carcitis after inguinal hernia repair is most often due to completely excising a large scrotal hernia. صح. If you excretely excise the large scrotal hernia, this will compromise the blood supply of the scrotum itself. So it will lead to a kind of inflammation to the scrotum. So if it's a large, you can lay it open or excise part of it. I think this is what the answer is about. Any other question?
I think that's it from our side. Thank you very much, Dr. Ahmed, for giving us this lecture. It was really informative.
Thank you very much for having me.
No, it's been a pleasure. So on part of Search Kuwait, we have a few announcements that we would like to say. Our first announcement is about we have our first ABCs in clinical research. We will start that session starting on May 15. So I'm just waiting for them to pull up the slide to show you. To Dr. Sara Lioha. So she will introduce how to write research, how to publish the research, and how to critique a paper. It will be a series of lectures, like a webinar of lectures. It's composed of three different lectures with different components. So if you're interested in research, it would be an amazing opportunity for you guys to sign up for that webinar. And then we have another lecture coming up. It's called, and you can see here before I discuss the other lecture, you can see that you can sign up for all of these lectures through the QR codes. Just hold your phone up to the screen and you will be registered. And then we have our next surgical debate is going to be on May 15. It's going to be a debate by Dr. Salman Safran and by Dr. Ali Sayed. It's going to be about thyroid papillary microcarcinoma. They both have different perspectives and they will be discussing it with each other. This time it's going to be on May 15 because of Eid. It will be on, that's going to start inshallah May 13. So the lecture will be on May 15. Also with the QR codes, you can register for the next sessions. And we have one more announcement of the next lecture, the next surgical fix lecture. Which is going to be on by Prof. It's going to be by Professor. She's from the United States of America. Her name is Professor Tanas Bagala, and it's about thyroid malignancy. So it's going to be next Sunday. I'll just wait for them to pull up the slide so you guys can register for that. It's a surgical fix lecture. So can the host pull up the slide for them?
They can use the chat and the QR code.
Okay.
All three webinars are in the chat. You can all register for that.
Okay. So we'll leave it on for a while for everyone to register.